Welcome to Cardio Radio, a podcast of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio. This is Dr. Michael Constant from the Case Western Reserve University School of Medicine, and I serve as the principal investigator for Cardio, a statewide network of Ohio's 7 medical schools. Cardio is funded by the Ohio Department of Medicaid and shares best practices to improve cardiovascular health, diabetes outcomes, and to eliminate health disparities in Ohio's Medicaid population. The opinions and recommendations in this podcast are those of the presenters and not those of Cardio and its sponsors, and are not intended to be a substitute for medical advice. I hope you enjoyed today's podcast.
Greetings. I'm Chris Bernheisel, professor of family and community medicine at the University of Cincinnati, family medicine physician, and podcast lead for Cardio's Team Best Practices. In this podcast, we will discuss obesity treatment in primary care to not only lower weight, but also improve metabolic outcomes. This is part 1 of our 2-part series, with today's discussion focusing on obesity evaluation and medications for treatment. Part 2 will discuss weight loss surgical therapies. With me today are Dr. Ryan Farrell and Dr. Mike Holliday. Dr. Farrell is associate professor in the Department of Pediatrics at Case Western Reserve University and a pediatric endocrinologist at Rainbow Babies and Children's Hospital in Cleveland. Dr. Holliday is an associate professor in the Department of Family and Community Medicine at the University of Cincinnati and a family physician. Both guests are members of Cardio's Team Best Practices. Thank you so much, Mike and Ryan, for being here.
Thanks a lot for having us. Looking forward to the discussion.
Thanks, Chris. It's great to be here.
So let's go ahead and jump right on in. Ryan, I was wondering if you could share with us some of the important questions in taking a history when you have a patient with rapid weight gain or obesity.
Yeah, thanks. When taking a history of somebody with a history of rapid weight gain, assessing the totality of the individual is really critical. Obesity, whether it's in adults or in children, is often a multifaceted problem, and it's sort of the quintessential example of the interplay, between environment and genetics. Oftentimes the timing of weight gain in childhood may raise the suspicion for genetic or hormonal causes of obesity. So kind of identifying when that timing of that rapid weight gain begins is really important. Psychologic stressors, new medications that patients are put on, changes in energy levels or sleep patterns. These are all questions that I think can be pretty pertinent in working toward an underlying etiology. Identifying whether weight gain is due to exogenous versus endogenous changes is also kind of a helpful way to classify situations. So endogenous etiologies may include things like metabolic responses to medications, endocrinopathies, genetic syndromes. Exogenous etiologies may reflect, changes in energy expenditure or energy consumption, but this also may be somewhat overly simplistic as well. We recognize that weight changes may also reflect metabolic adaptations to the environment, including caloric restriction and active energy expenditure, those types of things. Certainly getting a sense of the duration of the problem is important to do, and understanding what efforts, whether it's successful or not successful, that patients have had or have attempted in the past are also important questions. Medications that predispose people to weight gain should be identified, as we kind of talked about already. And screening for symptoms of endocrinopathies like hypothyroidism or Cushing's disease are also pretty important to do. A really careful dietary history with assessment of things like sugar-sweetened beverage intake and processed carbohydrate consumption can also be really helpful, as these are often implicated as potential causes of weight gain, and particularly in children as well. A family history of obesity in either parent may identify individuals that are predisposed to weight gain, so that's also really important to take part in that history as well. And the genetic or epigenetic impacts of parental obesity are really difficult to untangle. It's probably a really big part of determining which individuals that we take care of are at the highest risk of developing obesity. The other thing that we really know is that adverse childhood experiences, particularly in youth, can really predict obesity later in life as well. So identification of major stressors, psychologic stressors at home is also really important to collect too.
Thanks, Ryan. I think I would love to hear more about the pediatric patient. What should primary care providers keep in mind when evaluating a pediatric patient?
So in pediatrics, getting a sense about a child's linear growth and their developmental milestones are probably important questions to ask at the same time, as those may help distinguish organic disorders or genetic syndromes. A weight trajectory can be very important to identifying those at risk of developing obesity later on in life. In particular, early weight trends are really predictive of obesity and the complications of obesity in older childhood and in adulthood. So as an example, absolute body mass index, or BMI, at the age of 3 is predictive of higher body mass indexes at the age of 14 and also in adulthood. But perhaps even more importantly, identifying the age of what we call the adiposity rebound can also be really helpful. So when we say adiposity rebound, what that is the point on a BMI growth chart where the BMI sort of reaches their nadir. Typically that's around the age of 5 or 6 years. And what we found is that patients with early adiposity rebounds, starting at maybe the age of 3 or so, actually have higher rates not just of obesity, but also metabolic-related consequences, things like insulin resistance and elevated blood pressures, triglyceride elevations by the age of 12.
Oh, that's fascinating. I'd love to switch gears a little bit. Many of our patients have lost weight in the past, even significant amounts, only to regain it later. Why is it so hard for many to maintain weight loss? Ryan, what do you think about that?
Yeah, so individuals with prior history of really significant weight loss may ultimately experience long-term metabolic adaptations that ultimately result in weight regain. So as an extreme example, this is a great study that I found in the Journal of Obesity. In 2016, a study of individuals from a season of The Biggest Loser, the TV show, showed that those individuals with the most profound weight loss after a very intensive dietary and exercise training intervention had substantial weight regain associated with long-term drops in their basal metabolic rate that were sustained for years, at least 6 years after completion of the intervention, with most of those individuals having measured resting energy expenditure about 500 kilocalories per day below what would be predicted based on their body composition changes in age. So there was only one individual that altered this weight regain, and they ultimately did that actually through undergoing metabolic bariatric surgery. This may inform subsequent difficulties in maintaining weight loss, particularly in individuals that have experienced a lot of this weight loss.
Wow, that's so challenging. Obesity is not just about excessive weight, though. It can lead to so many health problems. Mike, can you tell us the extent of comorbid conditions in patients living with obesity?
Sure, Chris. It's amazing to consider that there's over 200 comorbid conditions associated with obesity, but thankfully many of these are pretty common to primary care providers. So for example, 90% of patients with type 2 diabetes live with obesity, and hypertension, hyperlipidemia, and mental health disorders all have rates of 40% or more in patients who are living with obesity. And 90% of these patients have musculoskeletal pain from things such as osteoarthritis, gout, or plantar fasciitis.
Mike, what are your thoughts on how providers can help patients with obesity by addressing these issues?
I really think that these comorbidities are a great entrance point to have a discussion about weight. Addressing the patient's main concern first, such as fatigue or pain, really does respect the patient's autonomy and may uncover an important condition such as depression, diabetes, or obstructive sleep apnea. Once the patient's main concern is addressed, the door is now open to ask permission to discuss obesity and its complications more directly.
Ryan, with over 200 comorbidities, how should primary care providers evaluate patients with obesity for these conditions without getting overwhelmed?
Yeah, so you're right. I mean, there's a lot of things to sort of keep track of when you're managing a patient, adolescent or adult with rapid weight gain. So a good way that I think a lot of treatment guidelines have organized these comorbidities is to kind of group them into larger sort of subdivisions that all start with the letter M. So you can have medical, mechanical, and mental health comorbidities. So for example, as medical comorbidities, you think about sort of subdivisions of things like cardiovascular changes, things like hypertension, coronary artery disease, congestive heart failure, atrial fibrillation, those types of things. Metabolic consequences, things like dyslipidemia, diabetes or prediabetes, hyperuricemia or gout, and metabolic dysfunction associated steatotic liver disease. Even things like reproductive comorbidities, things like polycystic ovarian disease or hypogonadism, and on the whole, many rates of different cancers as well. So those would all be sort of medical comorbidities. And then in the mechanical domain, you can think about how obesity may impact different aspects of sort of your mechanical aspects of your body. So kind of going from head to toe, things like idiopathic intracranial hypertension is associated with obesity. Obviously, Dr. Holliday spoke a lot about airway and breathing, things like obstructive sleep apnea, obesity, hypoventilation syndrome, asthma. Gastrointestinal-wise, thinking like gastroesophageal reflux disease, skin abnormalities, including intertrigo, acanthosis nigricans, and vascular issues, things like deep vein thrombosis, venous insufficiency, those types of things. And then finally, musculoskeletal issues, which are very common in people that have rapid weight gain. They're at increased risk for things like osteoarthritis, back pain, and plantar fasciitis. So all those things can actually also put people at risk for things like disabilities that also further the cycle of gaining weight quickly. And then finally, in the mental health domain, thinking about mood disorders, things like anxiety and depression, eating disorders, substance use disorders, psychosis, all sorts of traumas and impacts on things like sleep are very, very common as well. So it's a good way to sort of summarize a lot of these comorbidities by kind of dividing them into those 3 M's: medical, mechanical, and mental health.
Yeah, thanks, Ryan. I think the 3 M's are quite helpful. Mike, how can primary care providers use the history, physical, and diagnostic testing to identify these conditions?
Well, the primary care provider can perform their usual general history and physical exam, and then making decisions about further diagnostic testing and referral, just keeping these comorbidities in mind. For example, the history might reveal pain from an orthopedic condition, dyspnea on exertion from asthma or heart failure, or acne and menstrual irregularities from polycystic ovarian syndrome. What also could be helpful are some standardized questionnaires. One would be the Stop-Bang questionnaire to screen for obstructive sleep apnea, and that stands for snoring history, tired during the day, observed apnea, high blood pressure, BMI greater than 35, age over 50, neck circumference over 40, and male gender. Scores of the Stop-Bang questionnaire that are 3 or 4 or higher indicates at least an intermediate risk of sleep apnea and warrants the referral for a sleep study. The PHQ-9 or Patient Health Questionnaire is used to screen for depression as well. After the history's been done, the physical exam can also show findings that would point to other diagnoses, other comorbidities of obesity. So, for example, peripheral edema and jugular venous distension could be from heart failure or pulmonary hypertension. One thing that may not be part of the normal physical exam in primary care, but may become more popular later, is the waist circumference. The National Institutes of Health was the first body to use thresholds for waist circumference in combination with BMI to assess a patient's metabolic health. They pointed the waist circumference of 88 centimeters or 35 inches in women and 102 centimeters or 40 inches in men to indicate increased risk of metabolic complications of obesity. Many now recommend a more universal measurement of waist circumference as a routine vital sign, with more nuanced thresholds that account not only for gender, but also for BMI and ethnicity. Once the physical exam and history have been done, there's some diagnostic testing that should be considered. I think in all patients, baseline metabolic testing would include lipids, hemoglobin A1C, serum glucose, and liver enzyme testing to detect the more common metabolic abnormalities that we see in these patients. Further testing such as hormone levels in patients with possible polycystic ovarian disease, thyroid function testing in those with symptoms of thyroid disease, or polysomnography in those suspected to have sleep apnea might be indicated based upon the history and physical.
Thanks, Mike. I think we're all anxious to talk about the medical and surgical options, but we also know that lifestyle changes are critical for promoting weight loss. Ryan, I was hoping you wouldn't mind just sharing what lifestyle changes we should utilize or promote for weight loss.
Absolutely. Yeah. So we should begin by prefacing that at the center of all medical weight loss treatments really should be the critical piece of lifestyle adjustments as really the pillar of obesity management. Lifestyle modifications really should focus on healthy eating habits and focusing on portion sizes. Again, as we talked about before, minimal sugar sweetened beverage intake and processed carbohydrate consumption, and really trying to achieve at least 30 minutes a day of physical activity. And actually, the American Academy of Pediatrics recommends usually 60 minutes in children, of which about half should be moderate to vigorous in nature. And these changes are necessary, obviously, to give all these patients good long-term habits to maintain over the course of their life. But we should also recognize that these lifestyle adjustments are unsuccessful for a number of individuals. In pediatrics, for example, there's these high-intensity family-based interventions that by definition, require at least 26 hours of direct face-to-face contact with healthcare providers. That's a lot of time, and it requires a lot of effort on the part of the families as well. While these programs have shown at least short-term improvements in weight and metabolic outcomes, they're not always universally available throughout the country. And moreover, as they're time and labor intensive, many patients and families just can't realistically participate in these types of programs for any number of social reasons. And I think this is in part sort of what informs the American Academy of Pediatrics decision in January of 2023 to start to recommend that healthcare providers offer patients 12 years and older with obesity the option of weight loss pharmacotherapy as an adjunct to health behavior and lifestyle treatment as well.
Wow, that's a powerful statement. As a primary care physician, I think that certainly speaks to me and probably is practice changing of that recommendation. Ryan, would you mind talking about the available medical therapies to address obesity?
So in the last 10 to 15 years, there really has been an explosion of new medications that have come out on the market that have consistently demonstrated pretty clinically meaningful weight loss with generally pretty good safety profiles too. So we're going to kind of walk through sort of chronologically and historically some of these older medications, and then we'll kind of move into some of these newer age medications that are getting a lot more publicity these days. One of the earlier medications to receive a U.S. Food and Drug Administration indication for obesity was orlistat, which is a reversible inhibitor of gastric and pancreatic lipases. And this medication ultimately results in impaired absorption of triglycerides and fats into the body with resultant weight loss. So this has been approved in adults for decades and was also approved for adolescents as far back as 2003. And orlistat has shown weight loss when compared to placebo. So in adult studies, an average of about 10 kilos or so was lost over the course of 1 year on treatment, compared to about 6 kilograms with placebo, particularly when that treatment was combined with a hypocaloric diet. In children, there were similar findings with an absolute drop in children that were treated with orlistat, an absolute drop in their BMI of about 0.55 versus a gain of 0.3 BMI points in placebo patients. But unfortunately, adverse effects are substantial with this medication, primarily related to the impaired fat absorption, with oily stools and fecal incontinence being pretty common. Close to half of individuals that take orlistat have had these types of GI side effects. So, orlistat still remains available. It's still FDA approved down to the age of 12 years, but many patients and providers have found other anti-obesity medications with typically better side effect profiles.
Yeah, I've heard of patients struggling with the side effects of orlistat. Many of my patients ask me about phentermine and the combination of phentermine and topiramate. What are your thoughts on these, Ryan?
Yeah, so in 2012, the FDA granted approval for the combination of phentermine and topiramate to treat obesity. So phentermine is a centrally acting appetite suppressant and also has some degree of sympathomimetic activity. And it's been approved as a monotherapy for short-term weight loss or in combination with topiramate for chronic weight loss management. So then topiramate is an anti-epileptic medication which has had well-documented side effects of weight loss, although the exact mechanism by which topiramate causes that isn't still precisely known. So several studies have been performed on phentermine and topiramate, following patients anywhere between 1 to 2 years on treatment. So phentermine and topiramate is typically started at a fairly low dose and then titrated upwards, so either a mid-range dose or a high-level dose, depending on the response to treatment, and then sort of balancing that with the adverse effects as well. Average weight loss, even on the low dose, was approximately 5% of body weight, which is clinically significant, while high-dose phentermine and topiramate resulted in an average weight loss of almost 11%. So importantly, this weight loss appears to be sustained while patients remain on the treatment. In contrast, some of the older anti-obesity medications like orlistat, you would start to see, even on treatment, a slow rise in weight, even when continuing on treatment. When looking at metabolic parameters, things like lipid profiles and blood pressure medication requirements, high-dose phentermine and topiramate appear to be associated with improvements on those types of comorbidities when compared to placebo as well.
Now, I'll have to admit, I've been real hesitant on using phentermine and the combination of phentermine and topiramate. What should I be watching for when using these medications?
So there are adverse effects that certainly need to be carefully monitored when taking this medication. There's certainly a potential risk for things like serotonin syndrome if phentermine is used in conjunction with other medications like serotonin selective reuptake inhibitors. Topiramate may also cause some difficulties in concentration, And then phentermine has the potential, because of its sympathomimetic effects, to also impact sleep patterns as well. You may need to monitor things like electrolytes, given an increased risk for metabolic acidosis. Again, trying to balance that with the positive benefits of these medications. If our patients are failing to lose at least 3% of their body weight by about 12 weeks on the top dose, that's around the time where we should really think about discontinuing phentermine and topiramate. Higher rates of things like anxiety and other psychiatric complaints have also been noted in trials when compared to placebo. So as a result, patients with underlying psychiatric conditions, things like severe depression or anxiety or suicidal ideation, it may be worthwhile to consider other anti-obesity medication treatments. Patients with a history of things like glaucoma, or again, using other medicines like monoamine oxidase inhibitors, really should not take phentermine or topiramate. And finally, with regards to pregnancy, phentermine and topiramate is a category X drug for pregnancy. Topiramate in particular has been associated with abnormalities including cleft lip and cleft palate in fetuses.
Many practitioners, remember, continue to be concerned about the association of phentermine and the heart disease. Can you quickly review this?
Yeah, sure. So previous combinations of phentermine with this other medication called fenfluramine were associated with valvular heart disease, though it appears really that the fenfluramine and its derivatives were the part that were actually much more closely associated with this. So as such, those medications were removed from the market. Phentermine as monotherapy actually appears to have a much lower risk of valvular heart disease, although those individuals that have pre-existing cardiovascular disease may need to be a little bit more cautious or consider sort of alternative treatments as well.
What about in children? Has this been studied?
Yeah, actually, so phentermine and topiramate has also been studied in children and was actually granted FDA approval for children ages 12 and up back in 2022, with 30 to 40% of subjects reducing their BMI by at least 10%, depending on the dose used. One episode of suicidal ideation occurred in the pediatric trial, and another 7 to 8% had other unspecified psychiatric adverse effects. So in that respect, some things to kind of monitor closely, particularly in children as well.
Thanks, Ryan. This is so very helpful. Mike, I was wondering if you wouldn't mind telling us more about any other recent combination therapies that have come out.
Absolutely, Chris. Another centrally acting anti-obesity medicine that can also be quite effective is the combination of naltrexone and bupropion. This was approved in 2014 and is believed to have effects primarily in the hypothalamus, acting on satiety centers and also modulating resting energy expenditure. Like phentermine and topiramate, naltrexone bupropion is approved for patients with a BMI of 30 or in those with a BMI of 27 with at least one weight-related comorbidity such as hypertension, diabetes, or sleep apnea. Importantly, in contrast to phentermine and topiramate, which is approved in children down to the age of 12, naltrexone bupropion is not approved in children and in fact has a black box warning for the risk of suicidality for those patients under 24 years of age. I'll mention a couple characteristics of each of the drugs in the combination. Naltrexone serves as an opioid receptor antagonist and thus may not be the most optimal treatment in individuals on opioid-based medications. Bupropion is a weak norepinephrine and dopamine uptake inhibitor used to treat depression and nicotine dependence. Both drugs appear to enhance pro-opiomelanocortin signaling that results in feelings of satiety and are synergistic when used together. In clinical trials, weight loss of 5 to 8% was seen in patients and was sustained over the study duration of 56 weeks. Naltrexone bupropion was well tolerated, although nausea and constipation were pretty common, affecting 20 to 30% of patients. Naltrexone bupropion is titrated up slowly over several weeks, and if weight loss of at least 5% is not achieved by 12 weeks, it really should be discontinued. There are some safety concerns when it comes to bupropion. In particular, bupropion is known to decrease the threshold for seizures, and it should be avoided in those patients who have a seizure disorder. And there's also some potential drug interactions, as bupropion strongly inhibits the P450 2D6 enzymes. As such, medications cleared by the enzyme should be started at the lowest dose and titrated up slowly. This includes tricyclic antidepressants, several selective serotonin reuptake inhibitors, and beta blockers.
Yeah, there's another class we really haven't touched on yet that seems to be in the news quite a bit. I think every time I turn on the news, it's out there again. Ryan, would you mind talking about the glucagon-like peptide-1 receptor agonists?
Sure. So glucagon-like peptide-1 receptor agonists, or what we'll just call GLP-1s moving forward, and also gastric inhibitory polypeptides, or we'll call them moving forward GIPs, have been used to treat type 2 diabetes over the last decade, but now they're also becoming much more regularly used in the chronic management of obesity as well. These medications have effects on gastric motility, so they result in early satiety and make patients feel full more quickly. And they have effects on appetite at the level of the hypothalamus as well. They also appear to have positive effects on insulin production and even beta cell mass. And there are presently now 2 GLP-1 treatments and then 1 GLP-1 and GIP sort of dual-acting agent that have an FDA indication for obesity. So we'll start off talking about high-dose liraglutide, which was approved in late 2014 for patients with obesity. It's a once-daily injectable GLP-1 dosed up to a max of 3 milligrams per day, which is a little bit higher than what we typically used for treating type 2 diabetes. It's been studied in multiple different circumstances with fairly consistent results. The largest trial that looked at this was called the SCALE trial for obesity and prediabetes that included over 3,000 subjects. Among subjects that received the high-dose liraglutide, average weight loss was about 8% compared to about 2.5% in the placebo group. And almost 2/3 of subjects that received liraglutide lost at least 5% of their weight, and a third lost 10% of their body weight, which is significantly better than the placebo. Importantly, these subjects were also on a 500-calorie deficit diet and were also exercising about 150 minutes per week as part of that clinical trial. So outside of weight loss, the benefits in other studies have suggested the lowering of things like hemoglobin A1C, fasting insulin levels, fasting glucose, blood pressure. In larger studies, subjects on liraglutide with type 2 diabetes and cardiovascular risk also had slightly lower rates of new cardiovascular events and overall mortality over the course of about 4 years, which is great as well. So side effects are still relatively common, and across the board, GI side effects, gastrointestinal side effects occur in almost 2/3 of individuals. Rare cases of things like pancreatitis, renal impairment, and very rarely suicidality have also been seen in patients on treatment. Of note, anyone with a family or personal history of medullary thyroid cancer or multiple endocrine neoplasia type 2 should not take GLP-1s. Liraglutide has also received approval actually in pediatric patients, again down to as young as the age of 12. So that was approved in 2020 after showing fairly similar benefits and safety profile in a pediatric age group. So importantly, in those studies in children, not every pediatric patient lost weight. In fact, about a third of the children in the clinical trial that led to its approval continued to gain some degree of weight. And so I think we should just reemphasize that these medications really should not be used in place of lifestyle adjustments, but really in conjunction with them.
Yeah, that's pretty important point there. Thank you, Ryan. Those are overall very impressive results. I think the one GLP agonist that we've heard the most about in the news has been semaglutide. Mike, would you mind sharing a little bit more about this medication?
Sure, Chris. Semaglutide is another GLP-1 that was approved in 2021 for obesity in adults, and it was approved in children aged 12 and up in 2023. It's administered as a once-weekly injection and titrated up monthly to the maximum tolerated dose. Its effects appear to be more potent than liraglutide, with weight loss in the Step 3 trial of over 16% on average in adults, and over 85% of patients treated lost at least 5% of their body weight. In adolescents, a 16% drop in BMI percentile was observed. In children, upwards of over 3/4 of subjects had a 5% BMI reduction compared to only 1/4 in placebo. And over half the subjects lost at least 15% of their body weight compared to only 5% in the placebo arm. The adverse effects also appear to be a bit more potent. Gallbladder issues may be present in up to 4% of patients, and pancreatitis is a low but still non-zero risk. In the pediatric study, 5% of subjects discontinued the drug due to various side effects.
Yeah, Mike, hasn't there also been a more potent treatment just recently approved by the FDA?
Exactly, Chris. So tirzepatide was just approved in the fall of 2023 for obesity in adults after the SURMOUNT-1 trial demonstrated high efficacy in weight loss. This drug actually functions as both a glucagon-like peptide and a gastric inhibitory peptide. It functions somewhat distinctly from the other GLP-1s that we've discussed earlier. Doses of up to 15 milligrams injected weekly are used and titrated up as tolerated. The average weight loss was impressive, about 15 to 20%, depending upon the dose, and only 3% average weight loss was experienced in the placebo arm. and 85 to 90% achieved at least a 5% weight reduction, which is known to be metabolically significant. Over half the individuals on the higher dose had 20% weight loss or more, compared with only 3% in the placebo arm. Cases of pancreatitis remained rare, and gallbladder events were around 1%. One-third of individuals experienced nausea. In previous trials, 4 to 7% of patients discontinued treatment due to side effects. There are other medications in the same or similar drug classes with perhaps even more potency that are actively being studied and will likely be reviewed by the FDA, with decisions on these drugs expected in the coming years.
So Ryan, you already talked about the fact that patients can have rapid weight loss and then rapid weight gain. They can gain it back. For these patients on this treatment, what happens to them after they lose all this weight? Can they come off of it?
Yeah, so all in all, these are medications that are generally, again, well-tolerated and safe and have, again, very unprecedented efficacy. But the big downside is really that weight regain appears to be almost inevitable upon discontinuing these medications. So this has been looked at in a couple different ways. In the Step 4 trial, there was an extension phase of that clinical trial looking at semaglutide in particular at the 2.4 milligram dose. So they did a 20-week run-in where patients were treated with semaglutide. And then after the 20 weeks, subjects were either continued on the treatment or they were switched to placebo. And in the patients that were switched to placebo, they ended up regaining about 2/3 of their weight when compared to patients that remained on treatment where they continued to lose weight. And that's actually all occurring even with continued lifestyle modifications of 150 minutes of physical activity and a 500 calorie deficit diet. They still continue to regain about 2/3 of their weight, which is really frustrating to hear. Similarly, in the Step 1 trial extension, so these were patients that, again, were on about 2.4 milligrams of semaglutide and were on trial for a course of a total of about 68 weeks, and then were abruptly discontinued off of treatment. And right in that same ballpark, about 2/3 of weight was regained by 120 weeks through the study. They did find that patients that had more significant weight loss maybe regained a little bit less weight. But on the whole, I think there's a lot that remains to be seen in terms of what's the optimal management plan for patients that are on these medications, if they need to stay on this medication for life or if they need to maybe reduce and kind of go on to a maintenance dose. These things are still unknown at this point, finding ways to sort of try to keep patients at a stable weight moving forward.
I want to take a moment to summarize this information. We have several options for both adolescents and also adults for weight loss. For our children, ages 12 to 18, we have FDA indications for liraglutide, semaglutide, and also phentermine with topiramate, as well as our older generation anti-obesity medications. For adults, we have all those that I mentioned for children, but we also add on naltrexone, bupropion, and tirzepatide. Providers should always consider concomitant medication use, any seizure risk in your patients, along with mental health comorbidities. We also need to take into consideration family histories, specifically MEN2B or medullary thyroid cancer, along with risk for diabetes and heart disease, so we can prioritize these medications for individual patients. There have been concerns risen about long-term costs of newer medications. Ryan and Mike, under what circumstances might you prioritize these medications given risk factors? Which patients are most likely to benefit?
So outside of the effects on weight, GLP-1s are also very effective in the treatment of type 2 diabetes, and they may even have some potential trophic effect on beta cell mass, meaning that those individuals with a predisposition to diabetes, either based off of race, ethnicity, risk factors, or family history, they all may particularly benefit from these medications. There's also some emerging data that suggests that some of these GLP-1 agonists may also have a direct cardiovascular benefit, even independent of the effects on weight and glycemic control. So for those patients with early evidence of cardiovascular disease, there may be reason for providers actually to prioritize these treatments for those patients compared to other patients that have obesity, either without diabetes or other cardiovascular risk factors. And then I think pediatric patients may also benefit potentially more compared to adults, given the fact that particularly with things like type 2 diabetes, the rates of complications and the aggressive nature of the disease are much more significant compared to adults.
Chris, I also wanted to bring up some of the cost issues with these treatments. This is definitely a large issue. GLP-1s have an annualized cost approaching $18,000 per patient. The Institute for Clinical and Economic Review suggested that semaglutide would need a price reduction of approximately 50% to meet industry standards of cost effectiveness. Phentermine, on the other hand, is among one of the more cost-effective treatments available, though it is only approved by the FDA as monotherapy for a short-term treatment of obesity. When used with topiramate, it also appears to be cost-effective, but durability of effect will be the biggest predictor of cost-effectiveness for that combination. Semaglutide appears to be more cost-effective compared to liraglutide. Liraglutide in the Step 1 trial resulted in a weight loss of 5.4%. Whereas semaglutide in the SCALE trial resulted in a weight loss of 12.4%. The total cost of therapy with liraglutide during the trial was estimated at $17,000 approximately, compared with over $22,000 with semaglutide. Accordingly, the cost needed to treat per 1% of body weight reduction with liraglutide is estimated to be a little over $3,000 compared with just under $2,000 for semaglutide. The Institute for Clinical and Economic Review also assessed cost-effectiveness of each of several classes of medications, including semaglutide, liraglutide, phentermine with topiramate, and naltrexone with bupropion, and found that phentermine, topiramate, and naltrexone with bupropion were cost-effective, while GLP-1 medications did not reach the point of cost-effectiveness. This does not incorporate adverse effects as part of the analysis or potential risks of these medications that might dictate one treatment be prioritized over another.
Hey, thanks, Mike. Ryan, if you wouldn't mind circling back and just address again for us what monitoring and adverse effects we need to watch for over time for each of these treatments.
As we discussed earlier, certain anti-obesity medications may have safety profiles that might make certain patients a little bit higher risk. Again, those patients with significant mental health disturbances, seizure history, risk of suicidality, or that are on certain medications may need to avoid medications like phentermine and topiramate or naltrexone and bupropion. Though quite rare, those with a family history, again, as we mentioned, of medullary thyroid cancer really should not be prescribed GLP-1s. And patients easily predisposed to pancreatitis also should probably consider other anti-obesity medication classes besides GLP-1s. Monitoring-wise, again, things like symptoms of cholecystitis should be assessed for at each visit. Symptoms that might suggest things like gastroparesis, any new psychiatric symptoms, screening for suicidality, and sleep disturbances really should all be kind of the monitoring questions that we should be inquiring about. New medications that patients are prescribed should also be assessed at each visit to make sure that we're not having any drug-drug interactions. And then just kind of close monitoring of things like vital signs and heart rate are also very important to do. Mild heart rate elevations have also been seen with some of the GLP-1s, so we should particularly pay attention to those types of changes in heart rate from baseline at each visit.
So we know unhealthy weight is such a massive problem in our country and globally, and we also know all these comorbidities are associated with it, yet very small number of patients that are eligible for these medications actually are prescribed them. Mike and Ryan, I'd love to hear from both of you. What do you see as the barriers in prescribing these anti-obesity medications more regularly?
You're right, Chris. There appears to be an overall slow adoption of the use of weight loss medications. Comparing to the prescription rates from 2012 to 2015 of sodium glucose cotransporter 2 inhibitors, also known as SGLT2 inhibitors. These were a newer class at the time for diabetes. Rates of newer anti-obesity medications have been comparatively lower. The adoption rates of the SGLT2s was nearly exponential, while the adoption rate of anti-obesity medications has been more linear. Considering the relative prevalence of obesity to diabetes, and that obesity is a major cause of diabetes, these results are paradoxical and suggest that there could be some systematic barriers against the prescribing of these anti-obesity pharmacotherapies. I think some potential barriers to prescribing these could include the route of administration, so injectable medicines can be a barrier for many, and also lack of understanding or comfort with these therapies, and on both the part of the patient and the providers could be an issue, and also concern for adverse effects, lack of coverage, and also out-of-pocket cost.
Yeah, and then, due to their frequent use, the other big barrier that we've experienced is just that these medications have really been under major shortages on a national basis at the time of this recording. And on the whole, I guess, just as an aside, I really do worry that, both the limited supply and differences just on the whole in terms of access to these treatments are going to have potential long-term consequences. When we look at like Medicaid-based insurances and then whether or not they're able to cover these treatments, while those with private insurance, either have better coverage or the financial means to acquire these medications out of pocket. I really worry that we're at a risk of sort of widening of healthcare disparities across different socioeconomic groups. We should emphasize that, over 10 years, back in 2008, over the preceding 10 years, the calculated cost of obesity and its comorbidities was over $250 billion. And moving forward in these next 10 years, the expected healthcare costs related to obesity are estimated to approach almost $1 trillion. So outside of the potential for cost savings when thinking about, the coverage of these types of medications, Medicaid coverage really should think about just those potential comorbidities and consequences of obesity as well. And thinking about the coverage of these anti-obesity medications, it's probably also more likely to benefit specifically those individuals at the highest risk of those comorbidities of diabetes and hypertension and cardiovascular diseases too. As we talked about at the beginning, we know that there's been a lot of studies that have shown, sort of the heritable impacts of obesity on offspring. And I think this is really something that is near and dear to my heart, as a pediatrician. This is probably my favorite study of all time. There was a study done in 2016 where they took men that were undergoing bariatric surgery and collected sperm samples from them both before and after their surgical weight loss. And what they found was that there were profound changes in sort of the epigenetic modifications of the sperm, the methylation patterns of different genes, which alters sort of how those genes are expressed. And what they found specifically was that the greatest impacts in those epigenetic modifications before and after their surgical weight loss were really in the genes responsible for appetite control. So these modifications are resulting in altered expression of these gene products that control our appetite and really have the potential to influence future generations in perpetuity, sort of moving down the line. So, really, this is important to think about, not just for this generation, but for next generation too. As of 2018, we've looked at, survey respondents that have looked at sort of who has insurance coverage for anti-obesity medications. And as of 2018, only about 20% of people surveyed reported having insurance coverage of anti-obesity medications. But when it comes to Medicaid coverage, it may actually be even worse than that. So as of 2017, Medicaid programs in only 7 states covered these medications. So, while the upfront estimated cost of covering GLP-1s, it's a large investment, we really should consider, the costs of, untreated obesity as well, factoring in things like absenteeism and disability and future healthcare use. So in summary, I think the coverage and the accessibility of these anti-obesity medications really needs to be not just thought of as a health issue, but also really just a social justice issue as well.
Gosh, I hate to stop this conversation. I've learned so much. Thank you so much. I want to thank both of you for this important discussion on obesity evaluation and the medications available to not only lower weight, but also to improve metabolic outcomes. We hope the audience has found this discussion helpful, and we invite you to explore more resources on the Cardio website to help you safely and effectively treat cardiovascular disease and diabetes. Please also stay tuned for Cardio Radio 44, which will discuss weight loss surgical therapies. Again, I'd like to thank both of you, Ryan and Mike, for joining us today, and we'll look forward to talking more next time.
Thank you very, very much for having us.
Thanks, Chris. It's been a pleasure.
And a special thank you to you, our listeners, for tuning in to Cardio Radio.
This concludes today's podcast. Be sure to visit cardio.org to learn more about the Ohio Cardiovascular and Diabetes Health Collaborative.